Good morning, everyone. Good morning, everyone. Dr. Kauthar, thank you for the introduction. Dr. Wiam, the organizing committee, thank you for inviting me. I'm honored to be here. Can you all hear me? No? Okay. Can you hear me now? Okay. So the title of my talk is Obesity Management. Here are my disclosures. So my focus of the talk is I'm going to be talking about the updated obesity guidelines, then moving on to effective lifestyle interventions, talking about the pharmacological treatments of obesity, and then ending with bariatric surgery. So as you all know, the prevalence of obesity and diabetes is on the rise. This is a slide from the CDC that looks at obesity, the prevalence of obesity and diabetes in the US from 1994 to 2000, 2014. And what you can see is the trend continues to go up. In fact, the prevalence of obesity is more than 26% in most of the states in the US. In our region, it's a very large problem with obesity prevalence rates of more than 30% in the GCC. Now, the point that we need to make is that obesity is a chronic disease, which is complex in pathophysiology and heterogeneous in presentation. The American Medical Association designated obesity as a disease in 2013. The Endocrine Society put out a scientific statement to support that on why obesity is a disease. And what they say is that obesity is an altered physiologic and metabolic state with genetic, environmental, and behavioral determinants, which results in increased morbidity and mortality. There's growing evidence that suggests that obesity is a disorder of the energy homeostasis system rather than simply arising from the passive accumulation of excess weight. As you all know, obesity is associated with many complications, including type 2 diabetes, dyslipidemia, hypertension, non-alcoholic fatty liver disease, just to name a few. So there are guidelines that were published by the American Heart Association, the Obesity Society, and the American College of Cardiology in 2013 for managing overweight and obesity in adults. So I'm going to go over these briefly. So recommendation 1 is to identify patients who may be at risk for obesity-related health problems. And to do that, we use BMI as an easily performed first screening step, with BMI of more than 30 indicating obesity. Class 1, Class 2, Class 3 obesity depends on the degree of how high the BMI is. We use waist circumference as an indicator for risk for cardiovascular disease, type 2 diabetes, and all-cause mortality. And we continue to use current BMI and waist circumference cut points in common use. This is Benjamin Franklin. You all know him from the $100 bill. Benjamin Franklin is a very important figure in Philadelphia, where I lived and I trained and I worked. He was the founder of the University of Pennsylvania, where I worked. So Benjamin Franklin, similar to many in the population, so even in the 1700s, had a BMI of 32. So Benjamin Franklin had class 1 obesity. So if I saw Benjamin Franklin in clinic in 1998, based on the NIH guidelines at that time, I would have told Benjamin Franklin that he needed to lose 10% of his body weight, because moderate weight loss of this magnitude can significantly decrease the severity of obesity risk factors. Now, if I see Benjamin Franklin now, based on the new guidelines, I would tell him that a sustained weight loss of 3 to 5% is likely to result in clinically meaningful reductions in triglycerides, blood glucose, A1C, and the risk of developing type 2 diabetes. Now, the more you lose weight, the greater the benefits. Now, this data comes from lots of trials. This is from the Look Ahead, which shows how even modest weight losses of 3 to 5% can lower your A1C. Now, the more you lose, the greater the effect on the A1C. You see similar effects with triglycerides. Moving on to the diabetes prevention program, which you're all aware of. So in the diabetes prevention program, there was 3,200 patients who were overweight or obese with impaired glucose tolerance who were randomized into 3 groups: a placebo group, a metformin group, and a lifestyle group. The lifestyle group were asked to cut down their calories to 1,200 to 1,800 calories per day, and they were coming for individual or group sessions over time. And in each of these sessions, they were taught something that's important to self-monitoring. Now, what you clearly see is that the group in the lifestyle group lost more weight than the metformin or the placebo. But what's more important is how this translated to diabetes prevention. So a weight loss of around 5 kilograms, so somewhere between 5 to 10% weight loss. So in the metformin group, there was a 31% reduction in risk of developing diabetes. What's more important is in the lifestyle group. So this is very important in your discussions with your patients in how you frame the discussion. Because the way I approach it, say I see a patient who weighs 100 kilograms. What I tell them, if you're able to lose 5 to 10% of your weight, this would mean around a 60% risk reduction in developing diabetes. Now we know that, as I mentioned earlier, that the greater the weight loss, that the greater the effect. So you have effects on hepatic steatosis, you have improvements in quality of life, and so forth. Lifestyle modification, as I mentioned, gives you somewhere between 5 to 10% weight loss. Now, the next question that patients will ask is, what diet should I follow? Now, in recommending a diet for weight loss, from the guidelines, there is no ideal diet for weight loss and no superiority for any of the myriad of diets reviewed. The whole idea is to prescribe a diet to achieve a reduced calorie intake. You choose a diet composition considering the patient's preferences and health status. So if I see a patient with diabetes, I tell them to do a lower carb diet. If I see a patient with heart disease, I ask them to follow a lower fat diet. This is based on more than a dozen diets that were reviewed. And the idea is you prescribe 1,200 to 1,500 calorie diet for women, 1,500 to 1,800 calories for men, and to do a calorie deficit of 500 to 750 calories per day. Where does this come from? So this is one of the many studies. This is called the pounds lost study, where they randomized patients into different diets, all with the idea of having a 750 calorie deficit. But they were randomized into different macronutrients, being high carb and lower carb on the other extreme. And they followed these patients for 2 years. And what you can clearly see is that the nutrient content doesn't matter. A calorie is a calorie. So based on this study, it doesn't matter as long as you're cutting down your calories. Now, what's important in all of these studies regarding pharmacotherapy, most studies that have to do with obesity, is that you see huge variation in response. So this is another study that looked at different diets. So Atkins, Zones, Learn, and what you clearly see is in each diet, people respond very differently. So you have people who lose lots and lots of weight, people who don't lose weight, and people who gain weight. So what I usually tell patients is if they were successful with a diet before, they should go back to following it. If they weren't, they should try something else. But the idea is to induce a calorie deficit. Now, I want to just briefly mention about where this is going, the idea of precision medicine. So the hope is that at some point we will be able to predict which person will respond to which diet. So the study that I presented to you earlier, where I told you that a calorie is a calorie. So they've reanalyzed the data and they've looked at certain SNPs from a gene called FGF1. And depending on the allele the patient has, so if you have the CC allele, you don't respond as well to a low-carb diet. But if you have a TT allele, you're more likely to respond to a low-carb diet. So when you reanalyze the results are different. It's the same study, but new conclusions, that dietary composition is critical. Now keep in mind that this research is still in its infancy. Other research has not found similar results. But the hope is that in the future, we will be able to get a blood test and tell you will respond to this diet. So the guidelines recommend that patients who are overweight or obese enroll in comprehensive lifestyle programs for at least 6 months, where patients are taught behavioral therapy. So structured behavioral change program that includes self-monitoring about weight, activity, with personalized feedback from trained interventionists. And the hope is that patients will lose somewhere of around 8 kilograms in 6 months, especially. So we know that patients who go regularly to these visits are able to lose more weight. So this is supported by commercial weight loss programs like Jenny Craig's, Weight Watchers. So you can enroll in, for example, Weight Watchers on the phone and get this behavioral programs. So the question now, and I want you to think about patients you see, personal experiences, or people you know who go on diets. What happens? Most of the time, they're able to lose some weight, but at some point, they start to regain the weight. So why does that happen? This study published in the New England Journal of Medicine in 2011 beautifully illustrates that. So they took 50 patients who were overweight and obese, and they put them on a very low-calorie diet for 10 weeks. They lost around 14% of their weight. Now, after that, they told these patients to try to remain weight neutral, not to gain weight. But what you clearly see is over the year is that they start regaining that weight back, similar to the patients that you see in clinic. So the question is, why does that happen? It's not from the lack of trying. So in this study, they asked patients during these 3 time points, when they first started, at 10 weeks, when they were when they lost the weight, and a year later. They asked them questions about their urge to eat and their preoccupation with food. And what you clearly see is that as patients lose weight, their urge to eat goes up and their preoccupation to food goes up. Even when they regain the weight back, it's still not back to normal. So think of the patients that you see. They lose weight, you tell them, do a 1200 calorie diet. The first week, the first month, they're able to do it, they're not hungry. 3 months later, they come back to clinic and they tell you, doctor, I'm doing exactly what you told me to do. I'm no longer losing weight, and all I'm thinking about is food, and I'm very hungry. Something that is not sustainable. So why does this happen? So they looked at certain hormonal changes in the body. So these hormones are involved in appetite regulation. So let's take, for example, ghrelin. Ghrelin is the main hunger hormone in your body. As ghrelin goes up, you get more hungry. So if you look here at baseline, as you lose weight, and then a year later, so your ghrelin levels go up. So as you lose weight, you become more hungry. As you regain the weight, it's not going back to normal. Other hormones, so PYY, CCK, amylin, leptin, these are hormones that suppress your appetite. What's happening to those? Those are going down. So what this really is happening, from this study, you can clearly see that a 14% weight loss produced changes in 8 hormones that encourage weight regain. So literally, your body is fighting you to regain the weight back. Your body is comfortable at a certain set point and will do everything it can to get back to that weight. So I'm going to briefly mention a case that I saw in Philadelphia around a year and a half ago. So she's 59. She came for medical weight management. She has hypertension, hyperlipidemia, migraines, and chronic back pain. She's on simvastatin, sumatriptan for her migraines, lisinopril, and pain medication consisting of hydrocodone as needed for her back pain. She has the typical story. So she started gaining weight gradually over time. She gained weight with each of her children. And basically from 2007 to 2017, she gained a total of 32 kilograms. She's tried many programs before, including Weight Watchers, MyFitnessPal, calorie counting. She's able to lose some weight, but then she stops losing, she gets frustrated, and gradually starts to regain the weight. So my question to you all is, how do you overcome this plateau phenomenon? Should we tell her to start a very low-calorie diet, tell the patient to increase her physical activity, start her on anti-obesity medication, or refer her to bariatric surgery? If I can get a show of hands, who thinks A, start her on a very low-calorie diet? B, tell the patient to increase her physical activity. C, start her on anti-obesity medications. And D, refer her to bariatric surgery. So I think we have a mix of patients, a mix of results. So the way I like to think about this is we talked earlier about why obesity is considered a disease. So how do you overcome this plateau phenomenon? The same way you overcome hypertension in someone who does not respond to a single antihypertensive. If you see someone whose blood pressure is 160/90, they're on hydrochlorothiazide. What do? You add another medication. So this is the idea. So treat diet and behavior like a medication. So this is a slide that I got from Dr. Lee Kaplan from Harvard Medical School, and which I think beautifully illustrates the stepwise approach to obesity. Patients first try to lose weight on their own. Some are successful, some are not. That's when they seek help. They see an endocrinologist, a dietitian, primary care physician. Some work, some doesn't. That's when you should consider pharmacotherapy. After that comes weight loss surgery. And then finally, even patients who've had bariatric surgery sometimes regain the weight back. And that's when you use post-surgical combinations. So anti-obesity drugs are approved for patients with a BMI of more than 30 or more than 27 with comorbidities of obesity like type 2 diabetes, hypertension, sleep apnea, debilitating osteoarthritis. The big change is that these medications are approved for chronic weight management, and I'll show you why later. So in the past, we would prescribe these medications for a few months. Patients are able to lose some weight, and then we'd stop them. There's a big change in this approach. The most important thing is that they are recommended as an adjunct to diet and exercise. Without those changes, it's unlikely to succeed. So this is a slide that shows how almost half of the adults in the US meet recommendations for anti-obesity pharmacotherapy, but only 2% get pharmacotherapy treatment. Think of diabetes. If you see someone with an A1C of 14, are you going to treat them, or are you going to tell them, let's wait till you make some changes? So you see someone with a BMI of 40. Why do we wait before we act? We tell them, try, try, try. 3 months later, they come back, and it's still the same story. So how do medications help? So lifestyle modification is crucial. As I said, without the lifestyle changes, this is unlikely to work. Lifestyle, you need decreased exposure to chips, foods. So if you have chips or chocolate in front of you all the time, you can resist them for a day, a week, but at some point, you're going to give in. So that's why the behavioral changes are important. But then what do medications do? They decrease your hunger, decrease your food preoccupation, and increase your satiety. This is a study that was published in 2005 by my close friend and mentor, Dr. Tom Wadden, and where he clearly shows how combining the two works better than each alone. So this is medication alone, this is lifestyle alone, and this is the combined treatment. You clearly see greater weight losses when you combine lifestyle changes with medications. So the Endocrine Society and the American Association of Clinical Endocrinology have guidelines for the use of these medications. Until last week, we had 6 drugs, and I'll talk about why that's changed in a bit. So you have phentermine, which is the oldest drug approved in 1959 for short-term weight loss. You have Xenical, which is a lipase inhibitor approved in 1999. You have phentermine topiramate approved in 2012. Lorcaserin, which is a selective serotonin agonist. Naltrexone bupropion, which is also called Contrave. And most of you are familiar with liraglutide or Saxenda, which is a GLP-1 receptor agonist. So how do we decide what drug to choose? This is based on efficacy, contraindications or drug interactions, dual benefits, side effect profile, and cost to patients. So I'll go through each of these now. So keep in mind, there has been no head-to-head trial comparing those drugs, and there will never be. This is a paper we published in the Journal of Clinical Oncology in 2016, looking at these trials individually. And looking at this, phentermine topiramate looks like to be the most effective, followed by naltrexone and liraglutide, and then lorcaserin and orlistat are least effective. Keep in mind, these are average weight losses. Individually, people respond very differently to these drugs. So someone might respond to lorcaserin, but not to phentermine. So it's the same idea that I mentioned earlier with diets. If one doesn't work, you can try something else. Hopefully in the future, with pharmacogenetics, we'll be able to predict who responds to what drug. This is from the Endocrine Society, another way of looking at this. So 5 to 10% weight loss are very important parameters to look at. So from the phentermine topiramate, almost 50% of patients are able to lose 10% of their weight. 33% of patients on liraglutide are able to lose 10% of their weight. This is the 5%. I'm sorry I'm going a bit quicker just because we're shorter on time now. Looking into contraindications and cautions. So you have to keep in mind a few things. So patients with seizures or elevated seizure risks should not get bupropion because it lowers your seizure threshold. Patients with uncontrolled hypertension should not get bupropion. Phentermine is a sympathomimetic, so patients with coronary artery disease should not get that. Patients with pancreatitis should not get liraglutide. I just want to mention this part. So I always get asked by patients about the link of liraglutide with thyroid cancer. It's in rats, not in humans, and specifically it's medullary thyroid cancer, which is extremely rare in humans. So what the FDA says is to be on the safe side, do not prescribe liraglutide to patients with a history of medullary thyroid cancer or MEN. So just to confirm, it does not increase thyroid cancer risk. So in terms of the dual benefits, the next thing to look at is if I see a patient, so bupropion is approved for smoking cessation and for depression. So if I see a patient who wants to lose weight and wants to quit smoking, then I will go with the contrave, the naltrexone bupropion. If I see someone who has migraines, then I'll prescribe the phentermine topiramate because topiramate is effective as an anti-migraine drug. Patients with diabetes should be on liraglutide. And clearly the liraglutide 3.0, you lose more weight than the 1.8. Side effects. So in general, these are very well tolerated drugs. The way I like to explain it to patients is these medications will help you lose weight. They're curbing your appetite. So one of the side effects, which is the most common, is nausea. We're trying to curb your appetite. The opposite might happen. So that is the most common side effect with most of these drugs. Individually, phentermine, as I mentioned, is a sympathomimetic, so patients may get palpitations, increase in their heart rate, tachycardia. Orlistat is a lipase inhibitor, so it decreases the inhibition of fat. As a result, you can get GI symptoms, diarrhea, fecal urgency, etc. Lorcaserin is generally the mildest of those, producing only headaches. And liraglutide, as you all know, can produce some nausea and vomiting. So let's say we start a patient on a medicine. What do we do after that? A month later, we ask them to show up to assess for side effects. 3 months later, that is when we assess their efficacy for weight loss. If patients are able to lose at least 5% of their weight, that is considered good. Now, some patients may lose a lot more, but at the very least, they have to lose 5% of their weight for them to continue this medication. If they're not able to lose the weight, you should consider stopping the medicine and using something else. Every time you need to emphasize the behavioral therapy, because without it, it's not going to work. So going back to why these medications should be used chronically. So this is a study looking into patients who were on lorcaserin. So patients were randomized in the first year to placebo versus lorcaserin. Patients on lorcaserin lost weight, the placebo didn't lose as much weight. A year later, they re-randomized the lorcaserin group into placebo versus lorcaserin. What happens to the placebo group? They regain the weight back. If you have a patient on hydrochlorothiazide, their blood pressure is well controlled. If you stop the medicine, what is going to happen? Their blood pressure is going to go back up. It's the same idea. These medications are approved for chronic weight management. The obesity is a chronic disease, and we should treat it as such. Looking at the metabolic benefits. So this is a paper that Andrew Crawford from Dartmouth and myself published last year, looking at the comorbidity improvements. And it does have benefits, these medications, on comorbidities. So liraglutide will have the most effect on A1C. All of them will have benefits on cholesterol. All of them will lower your blood pressure, with the exception of naltrexone bupropion, which can cause a transient hypertension. Now, unfortunately, we don't have a lot of these drugs here. So what do? That's when you should consider using these off-label. So metformin is the safest, cheapest drug that has weight loss potential. On average, doesn't cause much weight loss. But patients with insulin resistance, you can see a lot of weight loss with it. So it's a good first-line drug to use. Patients with anxiety, with depression and smoking, you should consider using bupropion. Migraines, Topamax. So, and then GLP-1 agonist and SGLT2 inhibitors for patients with type 2 diabetes. I'm going to skip this question just for time's sake. So the patient that I presented earlier, because of her migraines, I started her on Qsymia, and her weight went down from around 122 kilograms down to 102. So what do we do next? So the question is, once the weight is stable for 3 months, you consider adding another anti-obesity medication. You use one with different mechanisms of actions for addition or synergy. Keep in mind that the guidelines do not endorse combining medications for weight management. So this is a slide showing how this works. So phentermine Topamax, I talked about earlier, is approved for chronic weight management. Here you see the weight loss with placebo, with phentermine 15, with topiramate 92. With each of these, you lose some weight. But look at the combination. At lower doses than the ones used individually, you lose more weight loss. That's because each one is targeting a certain part, a different mechanism of action. So that's the idea behind using combination drugs. Similarly, this is a study that's looking at canagliflozin and phentermine in non-diabetics. The combination produces more weight loss than each of these individually. So in my patient here, I added liraglutide after she plateaued, and she even lost more weight. So again, this is a success story. We've seen patients who don't lose weight, but the whole point is you can have significant impact. Now, there are some setbacks with anti-obesity drugs. A lot of them have been withdrawn from the market, and that's why people are often scared to try them. So these are drugs that have been withdrawn in the market. Unfortunately, last week, the FDA requested the withdrawal of lorcaserin, which I talked about earlier. So the reason for that is in a cardiovascular trial, where the outcome showed that it's extremely safe from a cardiovascular perspective, there was an increase in cancer risk in the lorcaserin patients. We still don't know what it means. There was a 7.7% increase in those who were taking lorcaserin and a 7.1% in the placebo. So it's not much. We still don't know, but regardless, the FDA asked for this drug to be removed. Thank you. So very quickly, I'm going to talk about what's new and coming, and hopefully I'll have a bit of time to talk about bariatric surgery. So what's new and coming in the field? Semaglutide. So what I like outside is I saw a label for semaglutide. So it's coming. So semaglutide is a long-acting GLP-1 agonist. It's a weekly injection that is currently approved for diabetes. Now think of this as the new Victoza. Now they are trying a higher dose, which hopefully will be approved in 2022, which shows a 13.8% weight loss without lifestyle changes. That's very impressive. So think of this. With lifestyle changes, you're able to see more weight loss. And what's even more amazing, and hopefully will be successful, is that they're doing a cardiovascular outcomes trial on non-diabetic patients who are obese. So the idea is, if you're able to show mortality benefits in obese patients who are non-diabetic, then insurance companies will rush to cover this. Because what we're saying is, if you have an obese patient and you treat them with anti-obesity drugs, then they're going to live longer. So hopefully, the hope is that in 2022, this will be approved. Next is something called Gelesis 100 or Plenity. This is a hydrogel that was approved for weight management. It was regarded by the FDA as a device because it's not absorbed, not metabolized, and has a mechanical mechanism of action. So basically, it's a pill. You swallow it, you take it with lots of water. You take it 3 times a day. And because it's a hydrogel, once you take it with water, it expands in the stomach. And as a result, you feel satiated. Now, if you look at the results, this is individually, you do see some modest weight losses. It's not much. But interestingly, as everything else, you have these super responders. So 26% of adults who took this medication lost an average of 14% of their weight. Again, emphasizing how you should individualize this treatment. So this was cleared by the FDA for use in weight management. A lot of other targets are coming into play. Hopefully, we will have GLP, GIP, and glucagon combinations to help with weight loss. So current pharmacotherapy is at around 10% weight loss. We hope that in the next 5 years, we should be at 15% weight loss. Now next, I'll skip this. We're going on to bariatric surgery. So very briefly, indications for bariatric surgery: BMI of more than 40 without comorbidities, or BMI of 35 with one obesity-related comorbidity. It's contraindicated in patients who have untreated eating disorders, alcohol, or drug abuse. 3 types of procedures that are most commonly done. The gastric band used to be commonly done, not commonly done anymore. It involves putting a silicone here and you inflate it, and it's a restrictive procedure. In general, this isn't done as much because of its modest weight loss, lots of complications, so 40% of patients end up removing it. The Roux-en-Y gastric bypass is considered like a gold standard. It's a combination of a restrictive and absorptive procedure. The sleeve gastrectomy is now the most commonly done procedure in the US, where you take out 75% of the stomach. So this is from the Swedish obese subject study. It's a prospective study looking at different surgeries. And what you clearly see 15 years down the line is that gastric bypass gives you around a 25% weight loss. So people lose weight, regains some weight, but then it plateaus. Gastric band provides around a 10% weight loss. Now, how does that compare to sleeve gastrectomy? So this is the STAMPEDE trial, 5-year outcomes. Type 2 diabetic patients who were randomized to medical therapy, sleeve gastrectomy, or gastric bypass. On average, gastric bypass patients at 5 years lost 23% of their weight, sleeve gastrectomy 19% of their weight, medical weight management only 5%. We really don't know how these surgeries work. There's lots of studies looking at changes in the GI hormones that we talked about, so changes in ghrelin, leptin, etc. But then there's other things that we're looking at, including bile acids, microbiome, etc. Now, what's very important from the Swedish obese subjects, and that's why insurance company covers this, is that you see a mortality benefit. So patients who have bariatric surgery, they have reduction in mortality of around 28% at around 15 years. So in summary, I'd like to say that obesity is a chronic disease and should be treated as such. Lifestyle interventions effectively reduce the risk of developing type 2 diabetes. Modest weight losses of 5 to 10% is medically significant and can improve comorbidities and outcomes. Weight loss with lifestyle changes is difficult to maintain long-term. We should consider the use of anti-obesity medications in conjunction with lifestyle. And finally, bariatric surgery causes profound and durable weight loss. So this is a slide from the mainstream media, from the New York Times, about how I like to think about this. So one weight loss approach fits all? No, not even close. Thank you very much. I'm happy to take questions.